Dr. Steve Kraus here. Most people get whiplash wrong. They assume that all whiplash injuries are the same, and they assume it heals in just a few weeks. And they assume that if care lasts longer than that time frame, well, then it must be excessive. And that entire framework is not supported by the scientific literature. In fact, long-term outcome studies showed the exact opposite. In a study by Gargan and Bannister on long-term prognosis of soft tissue injuries of the neck, patients were followed for over 10 years. And what they found was that symptoms often plateau at around 2 years post-injury. And if symptoms are still present at that point, they tend to persist long-term. Now, that alone should change how we think about care timelines. And more modern research confirms this. In 2022, a paper by Dezoe on whiplash-associated disorders, advances in pathophysiology and patient assessment and clinical management, they showed that a substantial percentage of patients continue to experience persistent symptoms well beyond the acute phase. So today, I want to talk to you through something very simple, but it's really powerful. How do we determine treatment length based on injury severity? Because the truth is this, we don't treat whiplash based on time frames. We treat it based on the severity. And in healthcare, we grade injuries. We grade burns, we grade concussions, we grade ligament sprains. So we must grade whiplash. And if you don't grade the injury, it's hard to justify the care. And that leads to the single most important principle in this whole discussion today. Severity determines healing behavior, and healing behavior determines treatment duration. This is not philosophy, folks. It is biology. And that is exactly what the Croft guidelines are built upon. The Croft guidelines were developed by Dr. Arthur Croft, published back in the early 1990s, including his paper, Treatment Paradigm for Cervical Acceleration Deceleration Injuries. And then later, when he and Foreman put their book together in 1993 for their first edition, Whiplash Injuries, the Cervical Acceleration Deceleration Syndrome, and then they upgraded it to their third edition in 2002. So these guidelines weren't created in a vacuum. They were based on an analysis of over 2,000 real-world whiplash cases. And they combined that with outcome data and practice surveys. Now, here's what's really important. When cross projections are compared to real-world data like insurance databases, practitioner surveys, the average number of visits falls right into this same range, roughly the low 30s. And that tells us something critical. This isn't theoretical. It reflects actual clinical practice patterns all across North America. So let's talk about grading the injury. The Croft system classifies whiplash injuries into 5 different grades. Grade 1 is minimal. There's no range of motion loss, there's no ligament injury, no neurological findings. Grade 2 shows some range of motion limitations, but still no ligament damage and no neurological involvement. Now, grade 3 is where things get a little different. Things change. We have ligament injury present in grade 3 and some neurological findings. Grade 4 includes instability, disc involvement, and more significant structural compromise. And grade 5 involves surgical cases, potentially. The grading is not based on how much the patient says it hurts. It's based on objective findings. And that's the distinction that's critical, because whiplash is not just a muscle strain. The literature is very clear on this. There was another study back in the 90s by Barnsley and Lord titled Whiplash Injury, where facet joints were identified as the primary pain source in chronic whiplash cases. And then later in 2008, Ivancic and his team found that the cervical capsular ligaments were the cause of ligament laxity and translation findings in these whiplash injuries. And then Stemper in 2006, on his analysis of the anterior longitudinal ligament, he showed that demonstrating structural ligament damage leads to long-term instability. Why? Because those ligaments don't actually heal. They heal with scar tissue. So we're not dealing with simple soft tissue soreness. We're dealing with ligament injuries, joint dysfunction, and in many cases, neurological involvement, especially around the joint capsule. We know that ligaments don't heal quickly. They heal slowly, and often they heal incompletely with scar tissue and nerve sensitivity as a result. And that's why treatment duration needs to follow biology, not assumptions. So let's talk about the timelines, because this is where the biggest misconceptions exist. In the Gargan and Bannister study that I mentioned earlier, symptoms plateaued around that 2-year mark. And then in 2022, the Dezote review, which was a meta-analysis, they showed that persistent symptoms were very common after 2 years. And the earlier work that I quoted by Barnsley, they demonstrated that chronic pain originates from the structural joint injury, even when normal radiographic imaging looks normal and MRI is normal. So whiplash should resolve in 8 weeks? No, completely false. It's not supported by the literature. It actually ignores decades of research on ligament healing and chronic pain development. Now, some people bring up the Quebec Task Force. And to be fair, the Quebec Task Force, which was published back in 1995, Spitzer and colleagues, they did something very important. They created a standardized classification system called WAD, Whiplash-Associated Disorders. And it helped organize how we describe these injuries. But that had limitations. It is symptom-based. It doesn't evaluate ligament integrity. It doesn't evaluate or assess instability. And it doesn't provide a framework for treatment duration. In fact, follow-up research has questioned its predictive value. It doesn't predict prognosticated value. And another study evaluated the whole Quebec Task Force, and it showed that correlation with outcomes was not enough to guide long-term care decisions. Another study in 2008 by Kavolcha, he showed that the Quebec Task Force follow-up regimen was not accurate, and the classification did not predict persistent symptoms at 1 year. So the QTF was good for acute injuries, but not good for long-term prognosis. So it also doesn't determine the treatment. So Croft guidelines are far superior because Croft connects severity directly to the treatment frequency and the duration. So let's talk about what that actually looks like. And this is where most people misunderstand these guidelines. They think guidelines are rigid, and we know they're not. Guidelines are ranges, they're flexible, and they're based on severity in the Croft guidelines. So for a mild injury, grade 1 or 2, you might see care lasting for a few weeks to a couple of months, and that's appropriate. And for a moderate injury like grade 3, where the ligament injury is present, you're now looking at several months, often extending beyond 6 months, and in many cases, you're approaching or even exceeding 1 year. And this is not excessive, it's expected. And for moderate to severe injuries, which is the grade 4, that has instability present, possible disc involvement, that care might extend from 1 year to 2 years. And that is consistent with what we know about ligament healing and long-term outcomes. Now, here's another critical point. The Croft guidelines are not maximum prescriptions. They're upper reasonable ranges, and they are designed to prevent two things: overtreatment and undertreatment. Because undertreatment leads to chronicity. So we need to make sure patients are getting the proper care so they don't develop chronic problems. And this is also supported in systematic reviews in the literature, including Conlon back in 2005. They showed that early active care improves long-term outcomes. In 2007, Ferrari, in their whiplash diagnosis, treatment, and associated injuries, they emphasized that variability and recovery and the importance of individualized care was extremely important. And Cochrane and his colleagues in their study, they showed that passive short-term approaches alone are insufficient in most cases. So the treatment needs to be tailored. So let's talk about complicating factors for a minute, because this is where care often extends beyond the averages. And the Croft guidelines explicitly recognize that certain factors increase recovery time. So these include things like ligament instability, disc pathology, degenerative changes, previous injury, neurological findings, and other biomechanical factors from the crash itself. So when those factors are present, longer care isn't unusual, it's medically necessary. But it must be documented, because documentation is what connects the clinical reasoning to the medical necessity. So now let's talk about patient communication, because this is one of the most important parts of the care. Patients need to understand very early in their care that recovery is not going to be quick. They need to know that symptoms might stabilize within a few months, but full recovery may take much longer. And they need to understand that some residual symptoms might persist to that 1 to 2 year range, especially if those risk factors are present. This isn't meant to be negative, but I'm just being honest. It actually improves outcomes when you're upfront with the patient, giving them realistic expectations. Now let's address some common mistakes. When we treat whiplash injuries as a minor injury, that's a big mistake. And using arbitrary visit caps, 6 weeks, that's a mistake. So declaring maximum medical improvement too early is also a mistake. So when we rely on insurance guidelines to determine care, that's usually a big mistake. Insurance guidelines are designed for cost control. They're not designed to reflect tissue healing or injury severity. The Croft guidelines hold up because they're grounded in science. They're based on real cases, they align with the published scientific literature, and they match real-world utilization data. They create a clear framework: mechanism of injury, severity of injury, now the treatment plan, and then healing progression. This is what makes them defensible, especially in a deposition or court. So in closing, whiplash is not a one-size-fits-all injury, and if you don't grade the injury, you really can't determine the appropriate care. And if you don't understand healing, you can't predict recovery. And if you rely on arbitrary timelines, you will either undertreat the patient or misrepresent the condition. And the Croft guidelines solve that problem. They align care with biology and healing, they align documentation with science, and they allow doctors to deliver and defend appropriate treatment with confidence, because not all whiplash injuries are the same, and treatment should never be either. Now, I'm going to go into some examples on these severity grades. I'm going to show up here on the screen some different frequency guidelines. For example, you're going to find that grade 3, for example, moderate. The patient frequency could be daily for 1 to 2 weeks, then 3 times a week for 10 weeks, then 2 times a week for 10 weeks, and 1 time a month for 10 weeks. The total care of that first part might be 4 months. The total duration up to 29 weeks. And there might be 33 visits inside of that moderate grade 3 injury. Let's take a grade 4, a moderate to severe case. Well, initially you're going to see them daily for the first few weeks, and then 3 times a week for a couple of months, for 16 weeks. And then they'll reduce down to twice a week for 12 weeks, and then eventually to once a month. That overall case could be 1 to 2 years long, exceeding 76 visits. So the guidelines allow for appropriate treatment to occur. Take a look at these Croft frequency guidelines for both the treatment duration and frequency, as well as the whiplash injury severity grades.